You see a 14-year-old in the clinic with a severe congenital breast anomaly, and the clinical reality just hits you instantly.
Oh, absolutely. It's heavy.
Right.
Yeah.
Because you're not just managing an aesthetic tissue defect, you are managing immense psychological weight, peer rejection, identity formation, all of which require incredibly precise surgical timing.
Yeah, the psychological impact on these adolescent patients really dictates everything we do. I mean, as a surgeon, you're navigating this complex anatomical defect, but you're also managing a highly vulnerable patient whose entire, social survival feels tied to your surgical outcome.
Exactly. So today we're doing a rapid, high-yield clinical review of congenital breast anomalies, just a deep dive into hyperplastic disorders, tuberous breast deformity, and Poland syndrome.
Right, and this is a surgeon-to-surgeon discussion. We're talking practical approaches,
Yeah, surgical timing and real-world execution at the operating table.
which means setting the stage with the patient and the family in that very first consultation is critical. Securing informed consent is, it's half the battle before you ever pick up a scalpel.
For sure. You have to establish the surgical reality immediately.
Here's the key point. The goal is improvement, not perfection. If you set the expectation for perfect symmetry, you're just setting yourself up for failure.
Right, because the tissues change.
Exactly. The breasts will continue to evolve with age, weight changes, pregnancy. The family needs to understand that future revisions aren't just possible. They're highly likely.
So before we get into how to surgically correct these defects, we really have to understand the normal developmental timeline.
Yeah, you have to know the baseline.
Right. We need to know exactly when and where the embryological sequence went off track to understand why the tissue is behaving the way it is.
And that timeline starts remarkably early. I mean, breast development begins between 5 and 7 weeks of uterine life.
Wow.
You see these bilateral linear condensations of ectoderm, the mammary lines or milk lines.
And those go all the way down.
Yeah, they extend all the way from the axilla down to the inguinal regions.
Mm.
Now, in a normal sequence, almost all of that tissue regresses. Only a small focus of mammary tissue at the fourth intercostal space actually persists.
Right.
That tissue aggregate divides, it thickens, and by the 8th gestational week, it invades the underlying mesenchyme. Fast forward to the 3rd trimester, and placental sex hormones trigger canalization.
But the real clinical challenge for us begins much later.
Oh yeah, at the marsh when the breast progresses through the Tanner morphological stages.
And those Tanner stages, stages 1 through 5, they function a lot like a building construction timeline.
That's a great way to look at it.
Yeah, like Tanner stage 1 is prepuberdal, it's the empty lot. You start building the foundation with stage 2, elevating the breast bud. Stages 3 and 4 build up the internal structure, adding volume and that secondary mound. And then stage 5 is full maturity. The finished architecture, which is usually reached by age 16 to 18, you wouldn't start doing the final architectural contouring on a building when the foundation hasn't even settled yet,
No, you definitely wouldn't.
Operating before full maturity seems incredibly risky because you simply cannot predict the trajectory of the native tissue.
It is risky. Operating on a Tanner stage, 2 or 3 breast, introduces massive unpredictability. You just have no idea how the surrounding glandular tissue will respond to upcoming hormonal surges.
Right, the hormones are still fluctuating.
Exactly. If you intervene too early, you risk creating a secondary deformity as the breast continues to grow asynchronously right around your surgical site.
Wow, okay, so once that baseline development is understood, the first major clinical challenge arises when that tissue becomes abnormally sensitive to hormones.
Right, which leads to rapid, unpredictable overgrowth.
Throwing you right into the realm of hyperplastic disorders.
Yeah, and virginal hypertrophy and giant fibroadenomas are the 2 classic presentations here. Both result from an abnormal, exaggerated sensitivity of the glandular tissue to completely normal circulating hormone levels.
Wait, normal hormone levels?
Yeah, the levels are normal. It's the tissue's sensitivity that's the issue. With virginal hypertrophy, you see this excessive, unyielding proliferation. A patient will present with rapid onset macromastia literally just months after initial breast growth starts.
So in clinic, you're seeing severe shoulder grooving from bra straps, chronic intertrigo.
Postural changes, heavily thin skin with dilated veins. It's severe.
And the treatment is surgical reduction.
It has to be. You utilize standard breast reduction techniques, often requiring an inferior or supraromedial pedicle just to ensure viability over a massive distance, to achieve symptom relief and improve symmetry.
Now, giant fibroadenomas cause a similar rapid asymmetric enlargement, severely distorting the breast envelope. But
A massive pitfall. You have to definitively distinguish a giant fibroadenoma from a cystosarcoma phalodes.
Which is pretty rare.
Very rare. The incidence of phalodes tumors is less than 1.3% of these cases, but missing it alters the patient's entire prognosis.
Because it's a malignancy risk.
Exactly. A standard core needle biopsy can sometimes struggle to differentiate the two because of the overlapping stromal cellularity. Your initial surgical treatment is just simple excision of the mass.
Right.
You deliberately keep the pedicle in the location of the greatest normal tissue to preserve fullness and allow for immediate reshaping of the breast mound. However, and this is the kicker, if the final pathology comes back as a malignant phalodes tumor, your entire management shifts to oncologic principles.
Meaning re-excision for wide margins.
Yeah, and potentially requiring a total mastectomy depending on the tumor-to-breast ratio.
Man. Okay, so moving down the milk line, you encounter polythelia and polymastia. Polythelia refers to accessory nipples, which is surprisingly common, occurring in up to 5.6% of the population.
Yeah, you see it all the time.
But polymastia, actual supernumerary breast tissue, presents a much more complicated surgical scenario.
It really does. Polymastia almost always shows up in the axilla. It might just feel like a discrete lipoma or a prominent axillary tail of Spence during childhood. But once puberty or pregnancy hits, that tissue hypertrophies and becomes symptomatic.
And there's a serious clinical reality for you as a surgeon here.
Absolutely. That ectopic tissue carries the exact same rate of breast malignancy as normally positioned thoracic breast tissue.
Wow, equal risk.
Equal risk. If you choose to leave it in situ, it requires the exact same oncologic monitoring and mammography screening as the normal breast. Because of that lifelong risk and the physical discomfort it causes, surgical excision is usually the safest route.
Just take it out.
Yeah, you excise the glandular tissue directly and utilize closed suction drains to manage the dead space because the axilla is notorious for seroma formation.
Right, so gynecomastia is another volume excess issue, and it affects up to 65% of pubescent males.
It's incredibly common.
Yeah. It's a proliferation of ductal epithelium, usually idiopathic, and driven by transient hormonal fluctuations during early puberty. The textbook clinical guidelines states that if it persists 2 years beyond puberty, surgery is indicated.
That's the textbook, yes.
But in real life, you have a 15-year-old kid sitting in your office wearing a heavy hoodie in the middle of summer. He refuses to take his shirt off at the pool. He's facing severe social isolation.
Yeah.
I mean, waiting 2 years feels like a lifetime for that patient. Where do you actually draw the clinical threshold for operating versus making him just, wait out the hormonal clock?
It is honestly one of the most difficult conversations you'll have in clinic, but you have to hold the line on that timeline.
Really? You don't budge?
You can't. If you operate at age 14 while the hormonal milieu is still actively fluctuating, the recurrence rate is unacceptably high. You have to look the patient and the parents in the eye and explain that you need a stable hormonal environment to guarantee a permanent result.
That makes sense, even if it's tough to hear.
Right. And while you wait, you perform a rigorous preoperative workup to rule out the dangerous secondary causes. You check for testicular tumors, pituitary adenomas, liver disease, illicit anabolic steroid use.
Got it.
If the condition persists into late adolescence and the ultrasound confirms the tissue has fibrosed into a dense stroma, that is when you operate.
Okay, so what is the preferred surgical approach when you finally bring that patient to the OR?
The gold standard approach now is ultrasound-assisted liposuction, combined with direct perioral excision of that central fibrous bud.
So lipo first.
Yeah, the liposuction emulsifies the peripheral fat and glandular tissue, allowing you to contour the chest wall smoothly. Then you make a sharp, direct incision right at the inferior border of the areola to pull out that dense subareolar core that the cannula just can't break down.
But there's a notorious complication with that subareolar excision, right? If you take too much of that fibrous core, you end up with this severe contour deformity.
Oh yeah. Over-resection is the most common pitfall. If you get too aggressive behind the areola and strip the tissue all the way down to the pectoralis fascia, you cause a dishing deformity or complete nipple retraction.
Which looks terrible.
It casts an unnatural shadow on the chest wall, it looks completely surgical, and it's a nightmare to fix, often requiring secondary fat grafting. You must leave a small, uniform button of tissue directly beneath the areola to support it.
Tip.
And the post-op care dictates your final contour. You place closed suction drains, you require prolonged compression garments for at least 6 weeks, You institute twice-daily deep tissue massage starting at 1 week post-op.
What does the massage do exactly?
It helps the tissue redrape to the chest wall, reduces persistent edema, and breaks down the early scar tissue that causes contour irregularities.
Okay, so while hyperplastic disorders are primarily issues of volume, managing shape and structural restriction requires an entirely different surgical playbook.
Completely different.
Which brings us to the complexities of tuberous breast deformity and the broader dilemma of asymmetry.
When dealing with asymmetry, the golden rule of developmental timing applies strictly. You delay surgery until the breast is mature, usually 16 or older.
Right.
Operating unilaterally limits your surgical variables and dramatically increases your predictability. Performing a unilateral reduction or a mastopexy on the larger breast to match the smaller, more aesthetically pleasing breast is often the most reliable solution.
And if you're performing that mastopexy to correct droop, remember we are talking about unilateral ptosis.
Correct. Correcting unilateral ptosis on the larger side is an excellent way to achieve symmetry without ever introducing a foreign implant into the patient.
But how do you handle a severe asymmetry deformity in a much younger patient? Someone who is, deeply distressed, actively growing, but hasn't reached Tanner stage 5 yet.
In that case, you utilize a temporary tissue expander. You place the expander submuscularly, fill it to correct the immediate asymmetry, and just leave it as a placeholder.
And just adjust it as she grows.
Exactly. You adjust the saline volume sequentially over months or years in the clinic as her contralateral breast grows. It completely mitigates the psychological trauma during high school, and you preserve the skin envelope without compromising the final reconstructive outcome.
Then you just swap it out later.
Right, you simply swap it for a permanent silicone implant once she's fully mature.
Let's talk about tuberous or constricted breast deformity. This presents a really unique mechanical challenge. Because this isn't just a small breast, the tissue is structurally locked down and restricted by its own anatomy.
Yeah, the clinical features of a tuberous breast are unmistakable. You have a severely narrowed breast footprint on the chest wall. You have a contracted skin envelope in both the vertical and horizontal dimensions.
The IMF is elevated, right?
Yeah, the inframammary fold is abnormally elevated. The nipple to fold distance is incredibly short. And in 40 to 50% of these cases, you see pseudoherniation, where the breast parenchyma physically bulges into the areolar complex.
It functions mechanically like a tight belt cinched around a balloon.
That's a perfect analogy.
Yeah, if the base of the breast is locked down by a dense, constricting fibrous ring, the actively growing glandular tissue has absolutely nowhere to go. It can't expand inferiorly or laterally, so it just gets pushed forward, herniating right through the path of least resistance, which is the thin skin of the areola.
That concept aligns exactly with Grelot's theory of etiology. Grelot proposed that anomalous superficial fascial adhesions essentially tether the dermis directly to the underlying muscular plane.
Ah, so it's physically tied down.
Exactly. Because the density of that fibrous ring is highest in the lower pole of the breast, the tissue cannot expand inferiorly down the chest wall. It is forced to grow anteriorly, creating that tubular projecting shape.
And Grelot breaks this anatomical restriction down into a practical classification system based on which quadrants of the breast footprint are deficient, right?
Yeah, type 1 is a deficiency of just the lower medial quadrant, which is the most common and mildest form. Type 2 is a deficiency of both the lower medial and lower lateral quadrants, meaning the entire inferior half of the breast is missing its footprint.
And type 3?
Type 3 is a severe constriction. It's a deficiency of all 4 quadrants, leaving a minimal base and a severe tubular deformity.
So walk through the standard surgical approach for releasing that constriction and restoring the shape.
You utilize an infraareolar incision. This gives you direct, centralized access to aggressively score and release those constricting fibrous bands. You have to use electrocautery to systematically divide the adhesions between the parenchyma, the deep fascia, and the skin envelope.
Right.
You actively lower the IMF by dissecting inferiorly to create a new lower pocket, restoring that deficient lower pole. Then you place your implant. We almost exclusively use a dual plane placement here, subpectoral superiorly and subglandular inferiorly.
And that dual plane release involves dividing the pectoralis major muscle along its inferior origin, right? Allowing the muscle to retract upward.
Exactly.
That specific maneuver allows the lower pole of the breast parenchyma to finally drape and expand fully over the lower half of the implant.
Yep. And because the areola is almost always stretched out and thinned from that pseudoherniation, you have to control the areola size simultaneously. You perform a circumareolar mastopexy.
With a purse string stitch.
Exactly. You use a permanent interlocking suture, typically something like Gore-Tex, to run a purse string stitch around the areolar border, cinching it down to a normal diameter and preventing it from stretching back out over the implant.
Okay, so tuberous deformities isolate the fascial restriction to the breast footprint itself. But when the embryological defect extends deeper, involving the underlying musculature, the ribs, and even the upper limbs, we enter the multi-system territory of Poland syndrome.
Colon syndrome is exceptionally rare, with an incidence ranging from 1 in 30,000 to 1 in 100,000 live births.
Mostly males, right?
Heavily skewed toward males at a 3-to-1 ratio. It also affects the right side of the body 3 times more often than the left. The prevailing embryological theory is a subclavian artery disruption sequence occurring during the critical 6th and 7th weeks of gestation.
A regional vascular disruption perfectly explains the constellation of symptoms. Because the subclavian artery supply is compromised precisely when the limb bud and chest wall are differentiating, you see defects across the entire vascular watershed territory.
Right.
The pathognomonic feature is the agenesis of the sternocostal head of the pectoralis major muscle.
That muscle agenesis causes a distinct, profound subclavicular hollowing and a completely absent anterior axillary fold. But because of that watershed disruption, it rarely stops at the chest wall.
You see hand anomalies too.
Frequently. On the ipsilateral side, specifically syndactyly, which is the webbing of the fingers, or foreshortened digits. You see hypoplastic or severely deformed ribs, particularly the 2nd through the 5th ribs. In female patients, the breast deformity is highly variable, ranging from mild hypoplasia to complete aplasia of the breast mound and nipple areolar complex.
The Fuchs classification system maps out the severity of these defects to guide the surgical plan. A grade 1 patient presents with mild pectoralis, major hypoplasia, moderate breast hypoplasia, and no underlying skeletal abnormalities.
Right.
Grade 2 is moderate, featuring marked pectoralis aplasia, hypoplasia of the surrounding chest wall muscles, moderate rib deformity, and an absent breast.
And then grade 3 is the most severe. It's characterized by complete aplasia of the breast, the pectoralis major, the surrounding musculature, and major bone and cartilage anomalies.
So what's the surgical treatment?
It relies on a stepwise reconstructive ladder. For a grade 1 patient, a single-stage submuscular implant often produces a fantastic symmetrical result because they still have enough muscle and skin envelope to cover the prosthesis.
But for the severe cases?
For moderate and severe cases, grades 2 and 3, the skin envelope is far too tight, and there's no muscle to provide coverage. You have to use serial tissue expanders to stretch the skin, followed by a pedicle latissimus dorsi myocutaneous flap.
Rotating the LD from the back.
Yeah, you rotate the latissimus muscle from the back to the front of the chest to physically replace the missing pectoralis bulk and provide a vascularized pocket for the final implant.
But wait, there's a major clinical paradox with that plan.
Oh.
Yeah, if Poland syndrome is fundamentally caused by a regional vascular sequence defect that leads to severe hypoplasia of the ipsilateral chest wall muscles, isn't relying on a latissimus dorsi flap incredibly risky?
That is.
I mean, in real life, wouldn't the latissimus itself frequently be underdeveloped or compromised by that exact same vascular disruption?
Spot on. That is the exact clinical limitation you face in the operating room. In severe grade 3 Poland's patients, the latissimus dorsi is frequently deficient, fibrotic, or entirely absent.
So you could get in there and have nothing to use.
Exactly. You plan a standard LD flap, you prep the patient, and you realize there simply isn't enough muscle bulk to cover the implant, or the thoracodorsal vascular supply is completely unreliable. Furthermore, harvesting the latissimus muscle might further weaken an upper extremity that already suffers from hand anomalies, and syndactyly, permanently compromising their grip strength and arm function.
That's a nightmare. So if the latissimus dorsi is compromised and off the table, the surgical pivot requires moving entirely away from the regional chest wall tissue.
You have to move up the reconstructive ladder to microvascular free tissue transfer. Free flaps, like a DEP flap or a tram flap based on abdominal tissue, become your best option to bring healthy, unaffected volume to the chest wall.
There's another pitfall here, right?
A massive one. The vascular anatomy in Poland's patients is aberrant. They have notoriously high rates of subclavian arterial hypoplasia and anomalous venous return. The internal mammary vessels, which you typically use as recipient vessels for the microvascular anastomosis, might be hypoplastic or missing entirely.
So you need imaging.
You absolutely must get preoperative vascular imaging, a high-resolution CT angiogram, before you ever attempt a free flap. If you don't map the vascular anatomy beforehand, you will find yourself in the operating room with a harvested flap and zero adequate recipient vessels to plug it into.
Wow. Okay, stepping back and synthesizing the surgical strategies we've covered, a few critical realities stand out. Accurate anatomical classification, whether you're using Grelot to map the fascial restriction in tuberous breasts or Fucras to assess the musculoskeletal deficits in Poland syndrome, strictly dictates your surgical plan.
Absolutely.
And timing is everything, as operating on an immature, Tanner stage 2 or 3 breast introduces massive unpredictability. Finally, managing patient and family expectations is paramount. You are aiming for improvement, establishing symmetry, and restoring psychological well-being, not achieving anatomical perfection.
Well said. The surgical techniques we've detailed today, the precise dual-plane implant releases, the pedicled LD flaps, and the microvascular free flaps, they represent the current gold standards for these complex anomalies. But, the reconstructive field is moving incredibly fast, and the surgical playbook is already expanding.
Which brings up a fascinating forward-looking concept currently altering how we approach these defects: the rapidly evolving role of large-volume autologous fat transfer.
Yes.
Using Coleman's technique, or serial lipofilling, directly addresses the volume and contour deficits without the morbidity of major flap surgery.
Serial fat grafting is really the current frontier. We're already utilizing it extensively as an adjunct to improve symmetry and soften the edges over traditional implants. But as our techniques for fat harvesting, atraumatic processing, and multiplanar grafting become more refined, we're looking at a near future where the survival rate of the grafted adipocytes is highly predictable.
It's game-changing.
It is.
Yeah.
We're approaching a reality where serial autologous fat grafting could entirely replace the need for prosthetic implants and complex, morbid free flaps.
I mean, just imagine treating a grade 2 Poland syndrome or a severe tuberous breast deformity entirely with the patient's own adipose tissue. You completely avoid the donor site morbidity of a muscle flap, you eliminate the microvascular risks, and you bypass the long-term complication profile of a foreign silicone implant.
It represents a massive paradigm shift in how we approach congenital reconstruction. It forces every surgeon to rethink the established architectural rules. We're moving away from forcing the anatomy to adapt to a prosthetic device and instead using the body's own regenerative tissue to organically rebuild the missing footprint.
It brings us right back to the very first patient interaction in clinic, that heavy psychological weight carried by these young adolescents navigating the murky, complex landscape of congenital anomalies. We start the consultation by establishing the hard reality immediately. We are striving for improvement, not perfection. But as our surgical techniques evolve and as we increasingly harness the highly adaptable power of autologous tissue, you really have to wonder how close to absolute perfection we'll eventually get.